I am going to present this talk with this premise that all what we do, we can do it better, and two, all complication occurs because we make mistakes. So let's understand those and see how we can prevent them. These are my disclosures. So the mistakes occurs because of poor exposure. And those of you who have done the operations with a small incision will appreciate that certain part of the joint you don't see well and you guess it, okay, it is there and I'm good. Like in total knee with a small incision, commonest error is one of rotation of the implant, and posterolateral corner you leave cement. So those are too common because of lack of exposure. Improper soft tissue balance, and that occurs if you raise the joint line. And this occurs because the tibial cut you made is not 10 millimeter on an uninvolved side. Say you made it 7 millimeter. If you made 7 millimeter, now you are going to cut more posterior condyle of the femur to have the right gap, and to have a good extension gap, you have to cut 2-3 millimeter more of the distal femur. So it's a chain reaction, I call it. One leads to the other. Sizing of the component is another, under oversize. Poor tracking of the patellofemoral joint because of the rotational malalignment. Poor cement technique so that you don't have a good bond. Improper wound closure. And tugging and pushing and pulling of the soft tissue so it doesn't heal and have a delayed wound healing. And if you leave it too tight, as I said, a lot of pain in post-op period. So all what I said would lead to delayed wound healing. Delayed wound healing, 10% leads to infection. Hemorrhage, if you don't get a good hemostasis, especially the lateral inferior genicular, if that blows out, you have big hematoma. Arthrofibrosis, if you have too much pain and too tight a knee. Anterior knee pain, which occurs due to certain design and oversizing of the femoral component. Patellofemoral complication, the topic in itself, malalignment, instability, and improper fixation due to poor cement technique. So I did a meta-analysis and published here and listed the causes of failure of all published reports, and they are like this. Instability, polywear, and infection. Here's the list. So to simplify, I have put from my personal experience, these are the reasons I do revision. Infection, instability, implant failure due to wear or breakage, and wear and osteolysis, and loss of fixation. If you look at the published data on the failures, and these are 5 reports here, and note that they are all 5 to 7 year follow-up, and there are 200 or more patients in each, and the three main causes of failure: loosening, instability, polywear, and 4th, patellofemoral complication. So goal of surgery is to do the operation with less trauma to the soft tissue. Bone trauma we cannot change, then control the pain properly so that the patient can use the function of the knee. So I don't apply tourniquet because I believe tourniquet is the one cause of soft tissue damage to the knee. So if you use less, you probably will have a less byproducts of ischemia in the body. Also, avoid cutting the quad. And this is an important point, and I'll come back to when I show the slide. And retraction with angle Homan, which I use, are soft retractors, not pushing and pulling and tugging. Preserve the suprapatellar pouch, otherwise you get adhesions, and anesthesia, spinal epidural, and a mean pressure around 60 to 55. Preoperative patient education to inform on expected outcome, ensure the patient experience at the hospital is positive, pleasant, and memorable. Control the pain, involve social worker, physician assistant, nurses, physical therapists, and rehab people. Maximize range of motion in post-op, avoid flexion contracture, control the pain, progress the ambulation, stair climbing, and muscle strengthening after certain time period. Principle of the operations haven't changed in my thinking. Alignment in all three planes, soft tissue balance and flexion extension, maintenance of the joint line, proper sizing of the femur and tibia, and proper fixation. Surgical exposure you have seen before, so I will not spend my time. You do the operation in flexion, and here it is. You should not cut the quad here. When you go from here, you should go straight. Don't go that way. If you go that way, you will have a hard time balancing the patellofemoral joint. All right, rectangular gap I talked about, and this is an important slide that put the tibial tray covering the cut bone, and this rod should come in the middle. If it doesn't come in the middle, your cut is off. Entering the femoral canal is critical. It is on this line, from the patellofemoral joint to tibiofemoral joint, and just kissing that line is the hole. And that's the center of the femur. Extension gap, sizing the tibia, posterior femoral cut parallel to the tibial cut, restore the offset, correct size the femur, lateralize the femur, lateralize the tibia, rotate it properly, and if you did all that, your patella will track and you don't need to do any releases. Flexion gap parallel to the femur, and here how to lateralize. This cortex, that cortex, and half of it. That's how you lateralize. And when you lateralize properly, the lateral condyle is a little narrower than the medial side, because that's where the bones are. Patella, I'll talk more, so I'll skip this. Check the stability in flexion, proper cement technique, and here I'll say I heat the cement so it sets within 7-8 minutes. And apply on both sides and pressurize it. And closure, close the dermis well, otherwise you'll get an ugly scar. Prevent infection by prophylactic antibiotic, proper draping, avoid OR traffic, consider OR hoods and laminar flow, limit the operation time, and meticulous closure of the incision. If you do this, such a knee should look like that, a cut at 90 degrees, a lateralized femur, good cement mantle, both in epilateral, slight posterior slope, and the way to judge it, you extend this, it should cut the anterior cortex. I thank you for your attention.